Welcome back to our second session today. At this time, I'd like to introduce our second speaker, Dr. Christine Depong. She is an assistant professor of biology at St. Louis Community College, where she works to teach future health professionals about the public and about basic biology, microbiology, vaccines, and immunology. After completing her graduate degrees in both biology and chemical engineering at Massachusetts Institute of Technology, Dr. Deppong received her PhD in immunology from Washington University, where she also completed a postdoc researching immunity within the respiratory system. Dr. Deppong is here today to discuss threats of re-emerging vaccine-preventable diseases. Welcome, Dr. Deppong.
Pull up my slides here. Okay, so today I'm going to talk about, again, threats of re-emerging vaccine-preventable diseases, and from our first couple of about vaccines in general, and some questions that might help, that might get answered in this session. So this session will be recorded, so I'm giving it live right now. I have no relevant financial relationships with the manufacturers of any commercial products, and I don't intend to discuss any unapproved or investigative use of any commercial products in this presentation today. So hopefully today, learn some more about the reemergence of some of these different vaccine-preventable diseases, and then have more confidence when talking to people about vaccine misinformation, which is just rampant in society right now. By using this information about these different vaccines and these different vaccine-preventable diseases. So what are the contributing factors to this reemergence of preventable diseases? So we all know smallpox was eradicated by vaccination, but other than that, we haven't been able as a human population to eradicate any viral, fungus, or bacterial diseases. So what are some things that contribute to it? So we live in a very global society. People are moving across the globe, across from state to state, from country to country with relative ease. In a couple of hours, you can be someplace completely different from community transmission of a disease to another. We have animal reservoirs, which host our zoonotic diseases, mammals, birds, insects being some of the main ones out there. And what happens with these is there's wildlife trade, there's deforestation, there's livestock. All of these things harbor different reservoirs, these different zoonotic diseases. We have overcrowding, and as overcrowding occurs throughout the globe, again, we push into areas where these animal reservoirs exist. And then we coexist with more and more wildlife and livestock out there. Social and political unrest is constantly going on in the world. You know, with the war in Ukraine, people had to move in mass from one place to the next. Things like vaccines go by the wayside when you're running from a tank. There's vaccine hesitancy, and we've seen that so much with COVID-19, how people don't want to trust the science for some reason. And part of that might be different messaging. There's public confusion. There's the way that medical doctors speak to one another. There's the way that scientists speak to one another, and we don't all even speak to each other the same, much less always have clear public messaging for everybody. COVID-19, obviously, as we've heard today and yesterday, has pushed back some of those normal visits that children especially have and aren't getting necessarily their normal childhood vaccines at exactly the right time. There's access to care, whether you're in an urban area, whether you're in a rural area. How far are you from where your primary care physician is? Do you have a primary care physician? This is a big deal for a lot of people. And then there's today, more rampant than ever, there are legislative efforts out there to weaken the childhood immunization requirements from state to state. So where exactly are we on vaccine? So overall, kindergarten vaccinations, as was talked about yesterday, they're down about 1% from the last school year. And the MMR, you know, measles, mumps, rubella ranges from anywhere from about 88% or 78% to 99% in Missouri. we're at 92.6%. For our DTaps, we're also at 92.6%. One large caveat to looking at these kindergarten vaccination rates is that kindergarten enrollment was down 10% during that first year of the pandemic. And so, you know, partially that may have been due to people just keeping their children at home before they could be back. But you ended up with having more homeschooling too, as society has become a bit more divisive these days. So I'm going to just jump right in and talk about a bunch of different re-emerging diseases. Now, I will tell you, if you go looking at the literature for a lot of information about exactly how transmission occurs and exactly how our immune systems respond to all of these different diseases, it can be spotty. So polio, because there's been a vaccine around for so long, there's not necessarily a lot of information out there. So we do know that it's a non-enveloped enterovirus. It's a positive sense single-stranded RNA virus. It is not zoonotic. One of the great things about a virus or bacteria that's not zoonotic is it has a real chance for being eliminated from the human population. And so that one day we could get to the point where no one has a polio vaccine. There are 3 strains. 2 of them have been eradicated. Transmission is mainly fecal oral, but if you have a area where there's low transmission, if there's very clean hygiene, then respiratory is also a problem. And the way that the polio virus gets into our system is predominantly through infection within your ileum. And CD155, which is a member of the Ig superfamily. Normally, CD155 interacts with killer cells. You have CD155 on the surface of your intestinal epithelium on M cells, so they uptake antigen from the inside, and then germinal centers of the Peyer's patches. So those Peyer's patches in your ileum are just lymphoid follicles of your small intestines, and the germinal centers that's where all of the affinity maturation of your B cells occurring. You get your plasma cells generated. They're actually going to make those antibodies, and you're getting memory B cell generation as well. The incubation period for polio is just 7 to 10 days. Clinical signs of a lot of viral infections, right? Fever, fatigue, headache, vomiting, stiffness in neck, pain in limbs. And what most of us associate with polio, for those of us who are young enough, I don't know anyone who had polio when I was a child. So 1 to 2% of infected individuals exhibit paralysis. Our immune response is mainly an IgA antibody. So those are the ones associated with your mucus in both interferon alpha and interferon beta, so 2 type 1 interferons. For those who are actually exhibit paralysis, it's thought that they may actually have an inefficient interferon, type 1 interferon response, and that might be what helps lead to that paralysis. We know that there 2 different basic kinds of vaccines for polio, right? There's the inactivated polio vaccine. The USA only uses this because there are no potential paralytic side effects. And then you have the oral polio vaccine. It is cheaper. It creates great immunity, which the IPV does not necessarily do. And you can, their contact immunity is possible. So when you vaccinate one person, other people who come in contact with them, especially in areas of poor hygiene, may actually gain immunity in this way. So now, most of the world has actually been certified polio-free, and there are just usually a few dozen cases in Afghanistan and Pakistan each year where it's very difficult to get in and vaccinate everyone. In 2017, there were 22 cases in Pakistan, but in 2019, there were 111 cases in Pakistan. Africa continent was certified polio-free in August of 2020. Okay, and so that was the last case of wild type polio, but there have been 2 cases this year, one in Malawi in February, and then one in Mozambique in May. In the case of the In Malawi, it was in a child under the age of 5 and led to paralysis. Now, after that case in Malawi, it led to 4.2 million children being vaccinated against polio. And Chima Ubanyowo, who is an epidemiologist School of Medicine, said that polio anywhere is polio everywhere. And I think that's just really a true statement for all of these vaccine preventable diseases. When you have 1 or 2 cases, it can very quickly spread again with the global travel, and they don't know where these cases came from that were in Malawi and Mozambique, and they were in children. So probably somebody brought it in since there's no zoonotic transmission. We have pertussis. Anyone who lives in Missouri has definitely heard about. I feel like when I was in talked about it, so we're whooping cough. Pertussis is caused by gram-negative Coccobacillus bacteria. Again, there's no known animal or insect reservoir exist, so this is a great one for possible eradication by vaccination. Okay, the of whooping cough, not surprisingly, respiratory droplets and coughing and sneezing. It has, pertussis actually has a large number of toxins that it secretes, and then also a large number of attachment proteins on its surface. And these attachment proteins allow it to attach to your ciliated respiratory epithelium. Okay, so the toxins that are secreted by the bacteria are the of the disease manifestation. Okay, so what eventually leads to that whooping. For example, tracheal cytotoxin, TCT, is able to cause necrosis of your airway epithelial cells. And so that's going to impair the mucus clearance. And therefore, that's going to, that's what causes that cough that people have when they have the pertussis. Those toxins can also lead to decrease in cytokine production. So once you have a decrease in those cytokines being made by those local immune cells, then less monocytes, so less phagocytes and less lymphocytes are going to be called to the area. And so you don't get monocyte differentiation in macrophages, so you are not getting phagocytosis and apoptosis induced in those the bacteria which causes the pertussis. The incubation period for like most viruses we'll talk about today are 7 to 10 days. The immune response in pertussis, so those toxins, of 5 of them, they can inhibit complement, phagocytosis, and your B and C lymphocytes. So they are able to suppress both your innate and your adaptive immune systems. There are still 160,000 people who die each year of pertussis throughout the world. Okay. One major issue with bacteria, a lot of my students always like to say, well, it's a bacteria. You just give someone an antibiotic. Well, we now know that there are a large percentage of the cases of pertussis in China are macrolide resistant. Okay, so that means resistance, right, to azithromycin and erythromycin. And so that seems to be the predominant type of pertussis now found in China. Again, like the very first thing I said about re-emerging global travel, people are moving from place to place all of the time. It doesn't take too much for some bacteria to move either. Vaccines available include DTaP or Tdap, right? Whether you're an infant or a little older. It's an acellular pertussis toxin. So this contains significantly less endotoxin, which causes those fevers that people don't like, than the whole cell pertussis vaccines. We no longer give, right, the whole cell pertussis vaccine in the United States. You can see here a timeline pertussis in the United States, very high until the 1950s. It comes down after the first pertussis vaccine was initiated. In the 1990s, that's when we changed from a whole cell vaccine to those acellular parts. So you just don't get as robust of an immune response because you don't cause as much of an inflammatory response. And so it's not able feed the adaptive immune system as much. And so boosters for this are very important. So instead of if someone gets go get a tetanus shot as an adult now, usually they should ask, right, for a Tdap. That's what I always do. Okay, a 2017 study showed a link between more non-medical exemptions from the pertussis vaccine and community levels of pertussis detected. And so just to show that as there are more exemptions, especially just between schools, that's going to mirror what you see quite often. Okay, measles. Okay, so in terms of the measles, measles is also obviously a virus, a negative sense strand, a negative sense single strand RNA virus, which is enveloped. It is zoonotic in its ancient origin. It's been around for thousands of years, but there is no known animal reservoir today. Okay, so again, another good one that could possibly be eradicated via vaccination. The transmission of measles is through droplets and aerosols. Okay, we know that measles is able to, the virus itself directly can enter through immune cells that are found in the airway epithelia, transport it to the regional lymph nodes. It's able to bind SLAM or CD150, and that SLAM can be found on B cells, T cells, and dendritic cells. So it's found on both innate and adaptive immune cells. So the incubation period, right, on average is about 10 days before the fever shows up. Fever is clinical side. The rash is what most people associate with measles who aren't doctors. So the viral replication that occurs of the measles virus occurs predominantly in the lymph tissue itself. And again, it goes from lymphocytes into epithelial cells. So some measles creates a very long-term, robust adaptive immunity, cell-mediated immunity. So that's a T cell-mediated immunity to the virus itself. But the problem is someone who gets the measles has a short-term immunosuppression and susceptibility to other pathogens. And an unknown mechanism, measles is basically able to decrease the variability of B cell receptors, naive B cell receptors in the area during its time of replication. Cell immune responses, so your T cells are, so your cytotoxic T cells especially, so CD8 positive ones, are clearing the virus, whereas their humoral immunity, we think may play a role in the neutralization of viruses. That is still an ongoing area of study. So approximately 140,000 people died of the measles in 2018 throughout the world. In the US, right, we have a live attenuated virus in either the MMR or the MMRV. Measles is a very highly contagious disease. And so to achieve herd immunity, you need 95% of your population to be vaccinated. So in 2000, the United States had eliminated the measles, which was great. But then you can see from this graph over here on the right, this is the measles in the United States in the subsequent years. So starting in 2010, there were 63 cases. In 2019, there were over 1,000 cases of the measles in the United States. You can see that in 2020 and 2021. So measles, right, is spread through respiratory droplets. So everybody put on a mask. Everybody socially distanced. People kept sick, stayed at home when they were sick. It's just going to slow down communicable diseases in general, especially respiratory spread ones. So there might have been a small organizations. Hopefully there's time to catch up before we have measles outbreaks again. But just to show you, until you actually eliminate a virus completely from the whole earth, it's not really eliminated in any one area permanently. Okay, so I'm sure many of you know intimately about the measles outbreak in 2015. It was all over the news. It was the outbreak that was traced back to Disneyland, California. From that outbreak, it spread to 7 states, to Canada, and also to Mexico. Okay. For those who it was known what their vaccination status was, 75% of the cases were found to be in unvaccinated individuals. So most of the cases were in people who had not been vaccinated. Approximately 20% of those US cases led to hospitalization. So um, there was a very new on what was the outcome of all this, what happened with this huge amount of media coverage, because it wasn't just in the New England Journal of Medicine or Science or Nature, also on NBC, CBS, ABC, all of those. Okay, so there was extensive media coverage, both in the traditional sense, but then also on social media, Facebook, Twitter, all of those. People were talking about it. So overall, the general population reported an increase in favorable vaccine-related beliefs, and this was especially true among college-educated parents. This outbreak itself also led to stricter vaccination policies by some pediatrician offices, and providers use that opportunity to counsel patients and parents about vaccinations in general. Okay, next we have the mumps. The mumps is a negative sense strand, single strand RNA virus. Again, transmission is mostly respiratory or oral. So it's able to bind sialic acid that are on respiratory cells. It has about a 2-week incubation time. The main clinical signs here are pain and swelling of parotid glands. And immune-wise, we make neutralizing antibodies, IgG, and IgA. So not just mucosal associated ones. Complications, highly neurotropic, meningitis, encephalitis. It's actually responsible for a lot of meningitis before the MMR vaccine. The mumps virus itself is able to block apoptosis. So it's in the MMR vaccine. You can see here that, again, low number of cases up to 2,000, and we see spikes since then. So again, this is probably due to people starting to question in the vaccine safety, anti-vax movement in general. Again, a respiratory spread disease. So we can see that during the pandemic, the numbers have gone down. Again, probably because everyone was wearing a mask. So influenza, I know everyone is very familiar with influenza already. So influenza is an enveloped virus. It's a single-stranded RNA virus. This one is zoonotic. Well, influenza type A is zoonotic. We all know that transmission is respiratory. Okay. The viral hemagglutinin proteins bind to sialic acid on your respiratory cells and then become internalized by endosomes. Our response, and what is responsible for most of feeling crummy when we have has multiple, is interferon related, and we have both an adaptive and an innate immune response to it. Influenza has multiple means of dampening that interferon response, which is going to allow it to replicate for longer before it's able to be cleared. Excuse me. 5,000 to 52,000. 5,000 to 52,000 deaths per year in the United States, 500,000 globally per year. People can get a seasonal vaccine. Okay, and that is 10 to 60% efficacious, depending on how good the manufacturers are at figuring out which kinds we're going to see more often. There are universal flu vaccines out there. The definition of a universal flu vaccine, that means it's going to be something that's at least 75% effective for all age groups for a minimum of 1 year against all flu A, and would be 3 to 5 years against flu B. There's a interesting clinical trial that has finished about a year ago, where what they did was they took those that they normally make the influenza vaccine against. And normally they make the vaccine against the different heads of the virus, so the hemagglutinin heads. And so mutate a lot. So what does not mutate a lot is the stock, but it's very difficult to get a robust immune response to the stock. So what they've done is they've made hybrids of these proteins where they take the stock, which stays the same, and put different heads on it for your different immunizations. So the first one, the head and the stock might match, and then your second shot, you get one with the same stock but a different head, so that your adaptive immune response, that memory immune response is still going to be against the stock, so that it can provide a much more robust adaptive immune response. Influenza, again, both innate and adaptive immunity are very important. Exacerbated, though, innate immunity can lead to very severe disease. For example, your neutrophils have a response where they make what are called nets, neutrophil extracellular traps. So they almost look like a spider web on a very molecular level, where they virus and bacteria in them. But the problem is that sometimes they make too much of this in the lung tissue in responses. In terms of adaptive immunity, you need both your CD4 positive T cells and your CD8 positive T cells. So you need your helper T cells. Those are required for class switching of the antibodies. They're also required for your optimal CD8 or cytotoxic T lymphocyte memory responses. And you are in need of your CD8 T cells or your TCLs in order to have optimal viral clearance. Okay, and so the last one I want to talk about a little bit is monkeypox, which is obviously everywhere in the news right now. So monkeypox is a double-stranded DNA virus. It's a zoonotic orthopox virus. In 2003, there was the first case outside of the African continent. It was actually in Wisconsin. What had happened was some rodents from Africa were shipped to a pet store. They mixed with prairie dogs. Prairie dog bit a young girl, acquired monkeypox. The transmission of monkeypox is fomite, droplet, and direct contact. So it may be respiratory if you have a very prolonged exposure to someone with it. The incubation is very long for this. It's 3 weeks. So signs: fever, lymphadenopathy, and then obviously the rash or the pox itself. Complications from this can include encephalitis and hepatitis. So immune response, there's not a lot known about this because this virus has been mainly limited to continent. We in the United States done a lot of research on this comparatively to other things that we've researched. There's a mouse model out there that suggests that natural killer cells are important for getting rid of monkeypox. They've done adoptive transfers in some mice to show that NK cells transferred can help protect in a gamma dependent manner. The death toll for monkeypox. So the overall case fatality is 1 to 10%, depending on which clade of you have acquired. They're currently renaming those clades. And so it looks like the clade of virus that is currently circulating in Europe and the North America is of the clade that is of the fatality rate. Some of these things are hard to tell though, because we know that smallpox vaccine is generally protective. It's 85% protective against monkeypox. But now, because we are so far from the time of smallpox, you have a very large unvaccinated population in terms of smallpox, right? I'm not old enough to have had a smallpox vaccine. Most people watching probably aren't. And those who have had a smallpox vaccination, your immunity is probably waned because it's probably been 40 or 50 years since you've had a smallpox vaccine. There's 2 main vaccines out there for smallpox that are protective against monkeypox. There's the AMCAM 2000, this live replicating one. Both of these are made with that. And then the Jynneos, which is a live non-replicating one. So the AMCAM 2000 is the traditional small pricks, so you get the scarification. Then the Jynneos is a sub doses that are 28 days apart. There was an MMWR on June 3rd about healthcare providers about this. So the first on the left, you can see monkeypox in the United States, or excuse me, in the world. So I just downloaded this data this morning, so it's very updated. So we can see there's about 2,600 cases of monkeypox that have been confirmed. It takes a while to confirm a case of monkeypox, especially in the United States. And so you can see there's just been this rapid increase of monkeypox during the last month. The United States, so this data was last updated last week. As of Friday, there were 113 cases in the United States. The CDC tends to update their monkeypox feed right about now. So you can go look at that afterwards if you're still interested in knowing more about that. So in terms of legislation and vaccination, we know that all 50 states allow for school vaccine exemptions due to medical concerns. 44 states allow for religious exemptions, and 15 states allow for philosophical. Vaccines are a hot button issue these days. So far, there's 66 state legislation bills in the US about childhood vaccination. Missouri House Bill 2009, which hasn't gone anywhere, though, looked to limit vaccine requirements for schools to only rubella, mumps, tetanus, pertussis, diphtheria, and hepatitis B, and would exempt private school students from vaccine requirements. And you know, the first thing that comes to mind out of all of this is that requirements to these known viruses, we constantly have emerging threats from viruses, and we're able now to make vaccines fairly quickly in the research world. And so it might not be prudent to limit it to that. There are a few states that have bills, such as Washington State added a bill in 2011 where they added, you have to add counseling healthcare provider as a stipulation for non-medical exemptions for vaccines. So a review looked at the data from 1998 through 2014. There was a 40% increase in vaccination rates after this bill went into effect. So just something to think about. So what can we do about all of this? So we know that pediatricians, doctors, primary care physicians, school nurses, these are people who are trusted by parents. And so that you guys can all talk to them. Help to develop or strengthen a diverse, representative, and effective school health advisory council in the school district my son goes to, right? They have lots of committees about COVID and different kinds of things like this to determine what kind of policies are they going to put into effect. It's important to have physicians on those committees, nurses, other healthcare professionals, epidemiologists. So if you're a physician, consider joining your local school district's school health advisory council. Get good at talking to people, reflective listening skills. So meeting people where they are. I think that's probably what I have found to be the most important thing to do when talking to students about these issues about vaccination is really listening to what are their concerns. What do they really know about vaccines? What might they not understand about vaccines? You know, today's parents, people who have very small children in general, have never seen with measles, mumps, rubella, polio. We've been lucky enough to these diseases for the most part, but that means people aren't familiar with them. And as we can see from that measles in Disneyland case, when there was an outbreak and then people started talking about it and understanding that get really sick, people can die from these things. And then they took the time to talk to their doctors or other scientists that they knew to learn about what are the effects, really letting people know vaccines are safe, but also being honest. There are side effects to vaccine. For the most part, it's probably going to be cranky the day after they get their vaccines because their immune system is doing something. I read an article last summer about, and it was in Science Immunology, talking about how the title of it was COVID-19 vaccine deposits about feeling bad. It was a great article, right? It talked about all the different toll-like receptors and what it was activating, which kinds of interferons were activating. I thought, this is great, but this is great for someone who knows a whole lot about the immune system. And so we need to find a way to convey that message to the public, to help those people who are on the fence about vaccines and to correct the misinformation that is out there about them and why, you know, it's normal to not feel good when you have an infection. That's your body's immune system working properly. Okay. And then also you can join the Missouri Immunization Coalition to better understand how we can all work together to improve immunization rates and to help in things like education and legislation. So, references, which you can check out in the handouts, some resources, and then if anyone has any questions.
Thank you, Dr. Depong. That was some great information about potential re-emerging threats. We have our first question today from Miss Linnell Phillips. She says, is there any news on vaccines for tick diseases, which seem to be on the rise in Missouri and in many other parts of the U.S.?
There are a few out there. There's one that they're working on right now for Lyme disease that I know of. And it's not actually, it doesn't get rid of the bacteria itself, but it keeps the tick from being able to embed long enough to embed the bacteria. So there are some out there that they are very much working on. And yes, ticks are definitely a problem when you go outside any place in Missouri. But Lyme disease is one we worry about, but I know that they are working on vaccines so that people, the deer
Mhm.
back to.
Thank you. Our next question comes from Miss Nicole Williams. She says, the return of which vaccine preventable disease scares you the most?
Oh, well, that's a good question. Um, I think probably, well, what would worry me the most out of all of them is just the fact that polio has almost been completely eradicated. And now it's just starting to pop up, and they don't know where it came from exactly. And so that worries me the most. As a parent, I'm not too worried because my child gets all of his vaccinations on schedule. But in general, yeah, any of these ones that are super spreadable, especially any sort of respiratory. So either I would say polio or measles are kind of top two.
Our next question comes from Dr. Scott Henderson. He says, data suggests that immunity to mumps wanes over time. What are your thoughts on strategies to prevent outbreaks of mumps in the previously vaccinated?
So I've read a couple of articles about in the you can give if there's an area, kind of do what they want to do with monkeypox, where you do a ring vaccination around these areas where there might be outbreaks. I wouldn't be surprised if someday we might give a booster in general to college age kids for these things.
Our next question is from Mr. John Shelby. He says, what vaccine preventable disease is the most likely to become a broadly endemic disease again if not addressed?
Oh, I would say it's any of them that are zoonotic. So they're just very hard to get rid of in the population in general. And so I think those are going to be your best bets for that. I think in general, there are more people who are starting to view the more traditional vaccines favorably. Actually, because of COVID-19, they were so worried about all of these mRNA vaccines that people want it like the Novavax because it's a more traditional vaccine. So I think people are a little more comfortable with those. And I think, honestly, in terms of just educating people on what exactly these diseases are. Again, people who are 25 and they're having their child, they have literally never seen any of these diseases other than the flu. And so they have no reference for how bad it can be for a small child. And I'll just give this quick example, and I know it's a little off topic of the question, but I have my students at the end of the semester on different diseases that are caused by bacteria and viruses. One girl chose pertussis, and she showed a 15-second YouTube clip of a baby who had whooping cough and the 10 seconds it took for the baby to catch its breath. And I think every single one of my students was almost in tears. They didn't understand that that's what could happen. And then they were like, well, why wouldn't we vaccinate babies? And why wouldn't everyone get vaccinated so this wouldn't happen to infants who can't get vaccinated? And so I think that kind of small educational moment can often do a whole.
That is a great example. And we have a comment, not a question for you, from Miss Linda Newman. She says, "Great timely presentation. I am old enough to have had smallpox vaccination, and my childhood friend had polio but survived without paralysis." So yes, definitely a great timely topic. And it looks like I have one more question. And this is from Mr. Kaleche Onya-Aka. He says, "War has played a role in re-emerging vaccine-preventable diseases in the past. Is there a concern with re-emerging vaccine-preventable diseases in Ukraine?"
So that's an excellent question. So there was, I read an article, it was probably in February or January, about how there had been a case of polio in the Ukraine that had come from a traveler from, I think it was Pakistan, I'm not exactly sure. But they brought polio with them. And so there was an article depicting going to have to flee, and then they're going to live in large camps in very close quarters. Or I'm sure everyone's seen the videos of people in the subways living down there at night during the bombings where you're on top of each other, no one's wearing a mask, which is all I can think during COVID still. And so yeah, I think that could totally be a situation that needs to be addressed, especially by the World Health Organization, as they make sure that children are staying up to date on their vaccinations, even in these camps. Food, water, shelter, safety, all important. But if we have outbreaks of any of these vaccine-preventable diseases, it could just very quickly become an epidemic and then spread further.
That looks like all the questions we have, Dr. Depong. Thank you for joining us live today and presenting live.
Thank you.
This brings us to the end of day 2 of the Missouri Immunization Conference. You will receive a link to today's program evaluation at the close of the conference today. The exhibitor booths will open momentarily, and we encourage you to visit them. When you visit our exhibitors, you will be entered into a drawing to win door prizes, including tickets to various sporting events from universities throughout the state of Missouri. Yesterday's door prize winner was Miss Monica Poston from the Northeast Missouri Health Council. Tomorrow, we will be hearing from Dr. Mark Ellis on COVID-19's emotional toll on healthcare professionals and Dr. Craig Rooney. He will follow up with a presentation on self-care for healthcare professionals. We look forward to seeing you tomorrow, and thank you again for joining us today.